Okay, welcome back to our second session of this equity symposium. I know some of our panelists were able to listen in on the last conversation. I actually walked out of there quite energized and thinking about a lot. And as we're going to learn with this conversation too, these are the types of topics that warrant far beyond an hour of time. But hopefully this creates an introductory forum where we can have some meaningful follow-up afterwards to continue. Just a reminder to our participants that we have the public chat turned off. However, private comments can be added if there are questions. We had some great questions come through in the last session that we were able to include. And so hopefully we will be able to do so again today. So in this hour, our esteemed panelists, all of whom are actually clinicians themselves in the medical profession, will address how mental health equity translates to clinical service delivery. And so it is my distinct pleasure to introduce you to the four panelists we have today. The first, before I do that, actually, just a reminder to the panelists, you can use your raise hand function in our discussion if you want to follow up. It flowed really well in the last conversation, so we can do so again in this time. But to begin, we have Dr. Nigel Kennedy coming to us from Mount Sinai Hospital in New York City, where he is the unit chief and an assistant professor in inpatient psychiatry. We have Dr. Ardell Walker, who is a member of the Cherokee Nation and medical director of the One Sky Center and National Resource Center for American Indian and Alaska Native Health, Education, and Research. We have Dr. Sidney Hankerson, also coming to us from New York City. He is the co-director of Columbia University Wellness Center and associate professor of psychiatry at Columbia Presbyterian Hospital. And last but not least, we have Dr. H. Wesley Clark, who is the Dean's Executive Professor of Public Health at Santa Clara University, former director at SAMHSA, and a specialist in co-occurring conditions and substance use. Welcome to all of you. Thank you so much for joining me today in this important discussion. Just as a start, to get your minds going, I ask you all to think about your role, the specific populations you have worked with, and how it translates to mental health equity. But I also encourage you to speak about your own identity in terms of how it has informed your work and ability to achieve equitable access for all. And as I said before, you can use your raise hand function if there's a follow-up you'd like to make to a comment one of your peers makes, although I will have some questions that I direct to specifically each of you. So let's begin. Dr. Clark, I'm actually going to start with you as our first question. You have extensive experience working in co-occurring addictions and substance use with a variety of different at-risk groups. So just to start the discussion, in your experience, what do you see are barriers to access for behavioral health care? Uh-oh, you are still muted.
Mute. All right, so what we're often dealing with regard to people with co-occurring disorders is the spectrum of co-occurring disorders, which include a wide range of conditions in addition to substance use. So you have post-traumatic stress disorder, depression, people with bipolar affective disorder, people with schizophrenia or other disorders of thinking, of trust, mood. And so that creates a complexity in dealing with co-occurring. So you've got stigma, access to and availability of providers who are comfortable with that spectrum of issues and the people who present with that spectrum of issues. You got the issue of psychopharmacology, knowing how to use therapeutic psychotherapeutic medications, understanding that the person who is presenting may also be experiencing a substance use disorder. So there's this fear that if I use an antidepressant or an anti-anxiety agent or an antipsychotic agent, that it will complicate things. And then, of course, when you're dealing with people with more disabling behavioral health issues that create things like homelessness or income support issues, that those things complicate because people are less able to keep regular appointments, communicate if they don't have access to cell phones or other forms of communication. And those are some of the complications. And then with the pandemic, what people are experiencing, of course, is this whole notion of despair. And that it also complicates things because you have an increase in suicidal ideation and a sense that there's no place to turn from the person who is experiencing those conditions and the person who essentially is trying to provide care to those people who are experiencing this situation when, as we heard in the last panel, everyone is going through some sense of having some psychological reaction to the isolation that has come from the lockdowns, the mask, et cetera, et cetera. I mean, a year and a half later, you're walking around with a mask and you still can't see people's faces, and there are no smiles anymore. So you, as a clinician, a smile has some therapeutic benefit, and there are no more smiles. So just in passing. So isolation is something that we have to deal with. So those are the key themes that surface in my mind.
And an excellent foundation too that we can offshoot as a group to talk through when you speak about making mental health and behavioral health services equitable, right? Yeah. So if we put that out there, Dr. Walker, I'll go to you next. In your role as a rural health specialist, as someone who's worked with Native groups, runs a large resource center, for folks. Where does your head go when you hear the things that Dr. Clark is talking about?
Well, the barriers are something we talk about all the time. Let me just give a real quick kind of a statement here. American Indian populations are very diverse. There are 574 tribes that are federally recognized. There are about 60 that are state recognized, and there are about 100 that aren't recognized that are still there. So it's very confusing how you distribute healthcare and work within a system that's so chaotic. Sometimes the states will look at the federal government and say, it's not our problem. You guys made the treaties, you deal with that. And so there's confusion in the process. It's a very large geographic area that we have to deal with. Remember, the Navajo Nation is larger than Switzerland, and trying to provide care when the roads are inadequate, there's not enough electricity, there's not enough water. It becomes an interesting delivery problem. And so medicine has to work with other parts of the system to provide the care that's needed. Many of the treatment facilities are isolated and they're hand-me-down. Mental health doesn't get the first rate of care as the rest of medicine. And so you start a new program and it's put into an older building. And we saw in COVID times, that was a disaster. We saw that unventilated, small rooms, hard to get to, became a real problem. And so you can look at the barriers and how this happens. And, I guess I'd say the other thing is how tribal people receive funding for healthcare is chaotic. It comes through multiple federal agencies and state agencies. And each one of those funding control points has a silo, and you can't move money around when something like a pandemic happens. You can't respond rapidly. And so those are barriers, I think, to mental health care in particular. And we have a lot to learn about how to do that. Now, I believe that's true for all special populations. I think that it's the same is true in inner city Philadelphia. And so we need to take a look at how we organize and orchestrate our network of healthcare for people. And I think that we'll talk more about that when we talk about COVID as well. But those are the points that I think are barriers to the problem.
Yeah, excellent points. And Dr. Hankerson, Dr. Kennedy, both of you kind of are on the opposite spectrum in terms of where you are practicing and where you work. being providers in New York City, you know, what comes to mind for you with regard to barriers? Because I think it's an excellent comment that they're everywhere. I think the context of them is very different. And often what is coming forward is the misunderstanding of need. What someone thinks there is a need and what actually is the reality. Dr. Kennedy, I saw you use this as your hand too. Just a reminder to you, can use the little phrase. I'm good at this. I've been teaching virtually for the past year and a half with 40 students. So
I'm old school. I'm going to use my actual hand.
No problem.
But just to echo what Dr. Clark and Dr. Walker have said, and you're right. You know, Dr. Hankerson and I work in inner city Manhattan, so it's kind of a very different landscape here. And I think that the idea of what mental health equity means has actually changed quite a lot in the last 5 years, definitely over the last decade. I did my training here. I actually did my medical training in London and worked in the inner cities there. And the idea at that time, not to show my age, but the idea that whether you are going to a Harley Street doctor or whether you come in through the emergency room with the inner city, you get the same treatment. And I think what we're realizing now that that's not necessarily equity. Give somebody the same treatment, whether they are coming through my Madison Avenue entrance from the projects that are across the street from us, and giving that person the same treatment as somebody that comes through the Fifth Avenue entrance on Central Park with some of the most expensive real estate in the world. They all come to us. But if I give a telehealth appointment to somebody who has no problem getting a $1,000 iPhone, it's a much bigger deal getting that follow-up with somebody who is struggling to just get food on the table day to day. So to echo the sentiments of Dr. Clark, I think we just have to understand that our people are individuals and that equity means delivering on all of those levels, whether it's housing, family support, or psychoeducation, and just understanding where the person exists in the world and trying to meet them where they are.
Yes, absolutely. And seeing somebody as an individual, which, you know, I think in training, even though we all have different disciplines, that is the premise, is we're supposed to treat our patients as the individual. But obviously that gets very lost when we have all other kinds of demands like insurance, Medicaid, hospital administration, all the things that we have to sort through. Dr. Hankerson, let's hear from you. You know, what is coming to mind for you hearing your colleagues here?
Sure. First, I'd just like to say thank you to the Kennedy Satcher Center for sponsoring this wonderful panel. It's really a pleasure to be here. I think just to echo everything that all the other panelists have said is that what we're really talking about seems to be social determinants of health. And so I think that really addressing some of these barriers and acknowledging and incorporating how we can address issues around food insecurity, housing instability, access to quality education, ultimately serve as barriers to healthcare. And just one other barrier that I would say is the role of structural racism. I think in the last 2 years, that has really come to the forefront as a recognized, barrier to access to services. And Dr. Walker talked about some of the challenges in providing care to a very diverse and heterogeneous group of Native Americans. The fact that the federal government does not recognize some tribes is a significant issue, and speaks to some of the structural issues that are barriers to care. And so I think that another issue that has come up in COVID as a barrier is distrust with traditional mental health settings. There's a tremendous amount of distrust, and especially in communities of color, with formal mental health clinics. And so I think acknowledging that history, acknowledging that distrust, and thinking about non-traditional ways to engage people in care, whether that's use of technology or trusted community-based settings, I think is important to address those barriers.
I think trust is going to be something that comes up over the 2 days that we're talking through in all of the different capacities we're speaking about equity, right? When folks feel invisible in the system by which they're being asked to access services, they have to feel like they can trust the service. And it's a historical problem that we have where we know there are communities that just don't feel visible. I think about folks who are undocumented. I think about folks in the tribal communities. I think about folks of color who have been historically traumatized by our medical system. So it makes me call upon the idea of meaningful collaboration, right? So one of the points that was brought up in the last panel is moving beyond just being a silo of being a behavioral health service provider and thinking creatively of how we can actually collaborate to provide equitable services, So I'll open this first to, Dr. Walker, in your role, what does meaningful collaboration mean to you?
Well, it's very important. I want to kind of start what Sydney's comment was about social determinants of health, because that's the network that we need to use to bring healthcare into the community. We need to work with the schools. We need to work with law enforcement, with homeless issues. All of these things need to tie together. Physicians especially are kind of an interesting group of folks. We were trained to open our doors and the people come to us to get their care and they leave. And that works for acute care medicine pretty well. But for chronic illness care, for those problems that don't go away, quickly, we begin to think about morbidity and mortality, and so the social determinants are really the steps that we need to take to be able to look at this in a more effective way. Physicians and other healthcare people need to get out of their office. They need to work. They need to know the people in the school system. When I visit a reservation, and if I immediately want to talk to the tribal council, and I want to look at the last 6 months of their tribal council minutes to see how much they know and how much they're talking about the problem they want me to deal with. And who are the people there that are champions to deal with that problem? And trying to form a task force from these other groups to help me move the system. Calling me in to work on a problem is not going to make it go away. I have to help mobilize the community and work with the problem. And as they gain confidence and they're empowered to do something with the problem, things get better. And then I can be much more of a consultative technical assistance supporter of the process. And as they go forward, I suppose the other thing is staffing. Do we have the staff and the quality of people that we need out there? In I would tell you, in Indian country, that's quite variable. And the turnover in staff and the difficulty of managing the situation. I believe we haven't talked about that much, but there's going to be a mental health crisis just in staffing, partially because of COVID, but partially because we're not training enough people to be in this field.
Yeah, I think that's a great segue too, to talk about the role of the workforce. So all of you are MDs by training. We had a great question from some of our participants that came through is, nursing and allied health professionals as well, who want to know what they can do to create a more equitable mental health space, right? And kind of break away from the totem pole of services that we have in a traditional hospital model and see like where we can collaborate further. But I think the workforce question is important. When you think of equity and behavioral health workforce, Dr. Clark, I'll take this one to you. What comes to mind as what works and what doesn't work when we talk about building a workforce that is equitable?
Well, I think we, as Dale was pointing out, historically, we have sort of a larger issue in terms of how behavioral health is regarded by the mainstream, so-called mainstream healthcare delivery system, from medical schools to your residencies, et cetera, and to a delivery system that has sequestered behavioral health away from, quote, primary care or healthcare delivery. The VA has moved toward a more integrated model with modular care, where behavioral health is in a modular system, but even then it's separate. So this whole notion about the whole person assessment, a whole person medicine, and personalized care has to acknowledge, as Sydney's talking about, and I go in terms of, Dale in terms of social determinants of care, we've got the structural determinants, and then we've got the social determinants. We've got a part of a structural determinant is the treatment of behavioral health apart from or so-called physical health, and yet the two things are interrelated. So if you start there with the training, then the people who gravitate toward behavioral health are told they don't need to know anything about physical health, and the people who gravitate toward orthopedics or cardiology are told they don't need to know anything about mental health. And so getting that whole system transformed is part of the complexity. That was mentioned, and that's going to be not an impossible task, but it's a daunting task. If we're going to talk about integrated care, we need to start with integrated education. And so we need another Flexner report, if you will, that deals with whole person health.
And it's making me think about something like the PHQ-9. So for our participants here who are not in the clinical professions, that's a classic depression scale. It's a 9-question depression scale that's offered. And often a lot of folks in my experience, patients actually get that scale offered to them more in a primary care setting or in an OBGYN setting than they actually do with a mental health provider, because they're accessing that service a lot more. But unfortunately, self-report is also a challenge, right? And I want us to talk about that because I think it has to do with inequity as well. A person's interest in answering accurately, if somebody asks them, are you feeling depressed, is very important, right? But they have to understand where that information is being used. What will they get out of that? And I think that's something we can talk about in terms of how our system tackles assessment. How do we tackle entry points of care? What does that look like? So Dr. Hankerson, I'll take this to you. You know, in your experience, thinking about training and assessment and Dr. Clark's point about a whole person model, what comes to mind of what works?
Yeah, so we have developed really wonderful collaborative relationships with faith-based organizations in New York City as a way to really engage people where they are. And kind of piggybacking on the last question, we've Dr. Olajide Williams, who is a neurologist at Columbia, and myself are co-directors of the Columbia Wellness Center, and we've developed a church-based community health worker training curriculum, where we basically recruit leaders from churches, their health ministries. These are trusted people from their church, who many of whom have experience in various sectors, from health to education to social services. We take them through an 8-week training curriculum that's based on the Centers for Disease Control model of training community health workers, and then train them in motivational interviewing, how to screen people for depression and anxiety. And now we're actually working with over 30 churches in New York City to identify people for depression, to provide motivational interviewing, and to be the bridge to connect people to care who otherwise wouldn't get it. And so I think that leveraging novel, kind of community and health system-based partnerships, like with schools, as Dale talked about earlier, like with the criminal justice system, can be a way to do what we call task shifting, which kind of goes to the point of training kind of non-mental health professionals in brief kind of evidence-based interventions to be able to support people and kind of be the bridge or the divide to kind of address the well-documented mental health services gap. Because there's certainly not enough psychiatrists to provide enough direct care for everyone that needs it. So we need to try to tier services based on severity of disorders, and task shifting is one promising approach, and engaging with trusted community settings is another promising approach to try to do that.
Right, and we've seen this work, right? I think about the HIV community, you know, the use of peer leaders to come through and support people getting access to care and reducing that stigma. I think it's a fantastic point to see how that translates to behavioral health service delivery. I saw Dr. Walker's hand first, and then I'll go to Dr. Clark.
Well, you know, you're asking a fascinating question. And to me, when I go to work with an individual or with the community in large, and they present a problem to me, I ask them what their theory is of how that happens. What do they understand? And do they have any knowledge in their background about what's worked in the past and what hasn't worked in the past? Now, what that does is it opens the door for them to have input into their own care. And, you know, we forget about that. You know, we're trained about how to medicate. We're trained about how to do these things that have to be done on a timely basis. You know, you have X minutes to see a patient. And it's fascinating. That is the most screwed up system in the world. When you look at needs of people who have high morbidity and mortality issues, that you need to listen to them and hear their story, and you need to be able to help them. Now, that's true of chronic illness. I think chronic illness care takes more than 8 minutes. We really have to do better than that. And I think that if we listen, it empowers the patient to be involved. And you also try to integrate some of their comments into the treatment plan so that they're engaged with it and they follow through. And it's a little bit of a negotiation, what you can offer, what they can offer, what the community can offer. And that's the way you get people to feeling like they're empowered and mobilized and safe to move on down the road.
And the word safe, I think, is a very key word always for me. I think as clinicians, we think about therapeutic safety, right? But I think, what does systemic safety mean? What does an environmental safety mean for a community that needs to feel safe accessing the service? Dr. Clark, and then Dr. Kennedy.
Yeah, as we restructure the system, we need to also recognize income disparities. Our reliance on peers alone needs to be couched in the context of we need to make sure that these individuals have access to career ladders that offer adequate reimbursement or adequate payment so that they stay on these tracks. Because I've often encountered people saying, yeah, I get a counselor's salary, but that's not enough to buy bread. So in terms of Dale's point about turnover, well, low salaries constitute turnover. So we have lawyers who are making $600 to $1,000 an hour, and we're going to pay peer counselors $15 an hour. Hello. That's questionable. So this income disparity is a major issue. You're talking about asking people to help people who have income issues, and they themselves have income issues. So yeah. Just wanted to point that out, that this is something that we are not dealing with in behavioral health.
And that I don't think we talk about enough. I mean, peer recovery is very promoted, but are we talking about equitable peer recovery and also acknowledging what we're asking people to do? I think that's a really important point.
That's
Dr.
right.
Kennedy.
Sorry, so many great points to speak to there, but just to follow on, I think that the idea that Dr. Hankerson raised already about triage, about effectively triaging people in the community and realizing that anybody can really offer some level of support, and recognizing that we all need to draw on our resources that we have around us. To go back to the idea of stigma as well, I think what I end up doing in my inpatient unit is trying to provide a lot of psychoeducation about what it means to have mental health care chronically, and what it means to have a psychiatrist, the nature of these illnesses, and just trying to reframe things away from these kind of DSM clear boxes, which are great for when you're doing research, but when your patient just says, well, what does that mean to me? So getting to the idea of symptoms and supporting people with the resources they already have, and then expanding that network seems to be very effective. For me, I find that relationships with community providers, with family, are so invaluable, because you see a patient in a very isolated, sterile setting, and that idea of where the person exists in the world, it comes from the people that know them best. And if families and community providers can give you a clearer picture, you can understand more about why this person has come to you at this moment in time. And as everyone has spoke to already, this goes far beyond the idea of just prescribing a medication. It's really about meeting that need in that moment. The other thing I would just say is that there's also a fear amongst a lot of people that I encounter that the crossover between legal services and mental health services, particularly when we start to talk about people who need a higher level of care, may need to go to the state system, people will automatically assume that as a punitive custodial sentence, and recognizing that mental health state hospitals have changed as well. This is no longer the idea of warehousing people that we had many years ago. But at the end of the day, the relationships you have with people are all important, and whether that's the patient, their family, the resources you have in the community, making the best out of what you have gives people the best chance of doing well in the future.
So I actually wanted to talk about criminalization, right? We have, I believe it's 42 states in the United States that have mental hygiene laws, which legally mandate behavioral health services for someone who's failed to comply, but ultimately it's also caused harm in the community as a result of psychiatric decompensation. But we also know that this stems from a longstanding history we have of criminalizing, especially people of color, for their mental health status. And I think we can't have an equity discussion if we don't talk about that, and what that looks like. And, where can we bridge the gross gaps I've seen personally? So the disclosure to the panel is, I know Dr. Kennedy because I was an AF team director in New York City. And so as a mobile unit director, I worked very closely with his team when our patients would go inpatient into the hospital. But many of ours were also forensic affiliated, recently released from prison, legally mandated for behavioral health services. And often it felt like we were mental health parole, that we are following someone to ensure their compliance so they just don't get in trouble, rather than figuring out creative ways to help them understand that this is for their wellness and their future. So, Sydney, I'll ask you, specifically talking to communities that have a longstanding history that's very ugly with the criminal justice system, what do we think we need to change in the dialogue about how mental illness is very frequently most diagnosed behind bars, when someone is receiving their first diagnosis, and how we can mitigate that when they're back in the community and accessing care they need?
Yeah, this is just such a multi-pronged question. I'd love to hear from the other panelists, but I think one example that I'll provide in giving an answer is the opioid overdose epidemic. We know now that there has been a huge shift in who is dying from opioid overdoses. In New York City, African Americans and Latinx individuals are more likely to die from an opioid overdose than non-Hispanic white New Yorkers. And that was a huge shift that we've seen over the last several years. And so what initially began as a mostly suburban and rural and Appalachia problem nationally has shifted into a challenge of urban centers in New York City, Chicago, Washington, DC, et cetera. And so one thing that we're doing as we're trying to engage communities of color about talking about the opioid epidemic is a tremendous amount of resentment, because people say there was an opioid epidemic in Harlem in the 70s and 80s with heroin. Mm-hmm. Where was treatment then? And so I think part of the discussion has to be to acknowledge where we as a healthcare system, where the criminal justice system has caused tremendous harm, and acknowledge then the inequities in the criminal justice penalties that are given for powder cocaine versus crack cocaine, and be very open and honest about that inequitable system, as well as call in community members to get their input on how best to frame the current opioid overdose epidemic, and what are their thoughts on how to address it. One thing that we're doing in terms of trying to address opioid overdoses in Harlem, which is the community with whom I primarily work, is to engage faith leaders, to engage members from the criminal justice system, to engage members of NYPD, to come together, to think through how to collaboratively frame this issue, as well as increase access to naloxone, which is an FDA-approved medication to reverse the impact of opioid overdose. For we know that in the inner city, most opioid overdoses are due to fentanyl, which is a synthetic, opioid. And so really also framing it as a social justice issue, really framing this as an issue around getting folks who have traditionally been marginalized and underrepresented in access to these types of services to really, frame this as a social justice issue to make sure these communities are getting the resources they need.
Yeah, I'd like to echo the issue about the opioid overdoses and the rates. It's the American Indian Alaska Native community that has the highest rate of opioid overdose. Both analysis, Kaiser Family Foundation did a recent analysis, CDC published a recent analysis. If you look at the raw numbers, it is a white phenomenon, but if you look at the rates per 100,000, it's an American Indian Alaska Native phenomenon, followed by African Americans and then whites, with Hispanics and Asians at the lower level. But there's a dramatic difference between whites and American natives, and increasingly between African Americans and whites.
Thank you for highlighting that too, because I think especially tomorrow, I was very forward that uplifting invisibility through this symposium was extremely important to me, and highlighting the experiences of people where there's a misunderstanding of the problem. So in the last panel, the theme was, if there's no data, there's no problem to a legislator, right? Someone who has to fund something or make a policy, if they don't see the problem, they don't have to think about it. And here we're talking about how that translates to service delivery as well. Are we accurately capturing the breadth of a clinical problem for a population and reaching their needs? Dr. Walker.
Yeah, it's really kind of interesting to me because you've got two hugely underfunded groups of people. The American Indian prison system is large. It's one of the largest in the country. But it's invisible. It is tremendously underfunded and is kind of seen as a timeout place to put people in so the community can rest. That's an awful thing to say, but it's seen that way in a lot of ways. It also, Wesley, I appreciate your comments. The American Indian in prisons is the highest per capita as well. Of any group. Also, the people who are killed by police is the highest. And the highest mortality from COVID is with Native people. And so you kind of see, while we're a small group, actually it's going to be 9 million in the new 2020 census, which is remarkable. But there's a lot of things that are not going well. And I go back to social determinants. When we look at the community and what's happening within the community, their access to all kinds of services and opportunity is limited. And your group this morning talked about data, and American Indian. When we show up in the big data analysis, we're other. We don't know what it is. The government put a lot of money into methamphetamine in Native community. We didn't even know the epidemiology of methamphetamine in Indian country, but we put money out there and we don't know what happened. And the same is true with special suicide projects. We aren't able to kind of study and follow through with what we've done. It's a very difficult thing to look at, but I think that it's easy to get lost without the data and without the understanding of, my goodness, when you really start digging around in this, we've got a big, big problem.
Dr. Kennedy.
Yeah, I think that that's highlighting a larger issue as well, is that the lack of funding across the board for basically these communities in need. And I think it would be remiss to not talk about the shortfalls with insurance, because the model that we have in this country, where we're so dependent on insurance companies for reimbursement, and this then feeds into the idea of retaining staff and training staff and giving them the idea that this is a career that they can support a family on and thrive. But it also ties our hands in so many ways as to the services that we can provide our people. And I think that particularly when people are self-employed, I think about how many people have lost their jobs during the recent pandemic and have had to go into the open healthcare marketplace. And it's sad to say that a lot of the outpatient services, particularly in the city, and I know across the country it's a similar issue, just are not in network with a lot of those companies. So instantly we've got people that have lost their job, they've lost their healthcare, they've lost their mental health support. And I think, just to go back to something that Roger said right at the beginning, I think we are actually on the cusp of a much broader mental health crisis that's going to take us into the next decade.
It's already being statistically covered. I believe the surge in demand for mental health and behavioral health services is about 250% compared to February 2020, prior to when we knew COVID was on the West Coast, but when it was nationally recognized here in the United States, there's a 250% increase. And it's dramatically increased in communities that have historically not actually sought mental health services. So the Asian American community, the Black community, the Latinx community, undocumented folks seeking out care, right? And what that looks like to be in a location where they're able to safely do that and not. And of course, then uplifting the experience of tribal communities, which, as Dr. Walker is highlighting importantly, are just left off the conversation in the first place. So my concern always, and I'm curious to hear how you all feel about this too, is about workforce burnout. You know, what can we do to mitigate this? That not only, you know, the last discussion kind of stemmed into what do we think about trauma-informed policy? Like, what is trauma-informed policy is what they were saying, right? And we all know trauma-informed care is something we all readily speak about, but what is a trauma-informed system, right? How are we thinking about this post-COVID? To think through, like, the entire population of the United States is traumatized. To an extent, we can say every single person has experienced adversity, the isolation alone. What do you think is our critical next steps, right, to help mitigate the burden of mental health crisis that is inevitable, is already happening, but is definitely inevitable? Dr. Clark, I think you're about to chime in, and then Dr. Walker, I'll come to you next.
Yeah, you're right. We have a reaction, psychological reaction to the pandemic. That, I think we need to be able to differentiate some of these issues, because the more global, everybody's experiencing something, requires a different approach than the chronic disease approach that people have. And so our society, in terms of a whole person or wellness perspective, needs to be able to do that. And if we can't do that, then we're lumping all experiences and all trauma experiences it's the same, and they're not. In fact, what we do know is that when everybody experiences something, and while people respond to that, it's a little easier, because if you do mobilize services or oriented around, we're all in this together, you get a different response from people. They do better. And you can see it, oddly enough, in the paradox of the anti-vaxxers who have mobilized, and they, in a sense, have their, and the states that have sort of followed suit, and Texas and Florida, where these people are, attacking nurses and schools and teachers, because they've all mobilized around that. Oddly enough, that's reinforcing psychologically. So we want to differentiate that, because I disagree with that. I mean, why would we expose teachers to kids who have no masks? And why do we traumatize the kids who are going to go to school with, they're the only ones who don't have masks and the teachers avoiding them? I mean, but the thing is that the parents are mobilizing around certain things. So we've got this environmental trauma that we should be dealing with. Then we're dealing with combat trauma, rape trauma, child abuse trauma. Those are not the same. And we can't just lump those into, and I guess it's what we are loath to do. And that is to actually split things. We want to lump everything. So all American Indians are the same. All Black people are the same. All Asians are the same. All white people are the same. If you are living in Appalachia, West Virginia, you're not the same as some white person living in out in off of Central Park in New York, Manhattan. Come on, they have whole different experiences. So the first thing we have to do is do a wellness thing, I guess, like Sydney is doing and Nigel are doing, is to recognize that none of these conditions can be lumped, as it were, and we need skilled people who can participate in the differentiation of these things, not treat all mental health issues as the same and all people as the same. So personalized care recognizes that, and so we need to be able to promote that notion, starting from either prevention or people starting to ask questions of the people who present for treatment.
Absolutely. And education is important. You know, I just think about kiddos I've worked with who have so much language available to them now to be able to talk through what they feel. I didn't know what depression was when I was in second grade. And then you have an 8-year-old that can come in and be able to say, you know, Miss Jai, I feel very anxious. I feel very depressed. It's pretty beautiful to see how that can actually come forward to help a child's life, and then giving parents the skills to sort through that. Dr. Walker, I saw your hand up earlier. If you wanted to jump in again.
Yes, Wesley, I very much enjoyed your comments and your enthusiasm for making it. I think it's very important that we look at the issues as you described. I wanted to share maybe a little bit of interesting and maybe good news about what's going on. You know, through the years, I've worked across the country with Native communities, and that means that I travel a lot and I'm out there on 200 different reservations. And so there's a great deal of work involved. When COVID hit, that all stopped, and everybody was kind of paralyzed in the process. And then, I work with a group in Iowa that has the national, 3 different national centers for American Indian mental health, and I'm their senior consultant. We got together and we formed Zoom meetings for 12 different issues. So we followed Wesley's comment about we have to deal with this differently. And we worked with the staff, and we were having meetings that have 200 people in them. And it was nothing like that's ever happened in Indian country. We could not bring those size meetings, and it was consistent. They stayed with the meetings over time. We focused first on the staff and trying to make sure how the mental health staff could hold it together, and how could they contact their patients because they couldn't do therapy in the room. And we encouraged them to just make phone calls to the people and just, instead of talking therapy, just say, how are you doing? What do you need? Is there, so just trying to be supportive and reaching out. And that gave the staff support and direction, but it also really had an invigorating response in the community. And so we worked with the staff, and then we talked about how they can protect themselves. We had all kinds of special webinars about how to take care of the family and their children, and so these meetings just grew. The interesting thing that happened out of that, and I think the Indian Health Service did an incredible job in working with communities. The American Indian population is also the highest vaccinated group in this country. Mm-hmm. And I think that the fact that we were able to put those pieces together and to reach out and continuously work with the people, and we're still doing it. We have a meeting coming up at the end of this month, and we don't know if it's going to be virtual or we're all making connections to it, but we don't know what's going to happen, at this moment. So to me, those are the things I think that we can learn from this, what's been put upon us. And I hope that Zoom meetings do not go away. I hope that we keep that process alive.
Dr. Hankerson will take your comment. And then I also do want us to talk about telehealth services, and what that can look like for access. But Dr. Hankerson, let's hear from you.
Yeah, I just think Dr. Clark's comment was brilliant about the importance of disaggregating how we think about trauma-informed care. And I am so heartened by the work of Dr. Walker. I think it's tremendous, the amount of community engagement that he has done with tribal communities to be able to increase, massively that vaccination rate. And I think that in thinking about trauma in particular, I think that, policymakers, we really need to think about historical trauma. When I think about tribal communities in particular and how they were uprooted and how their tribes were broken up and other communities that were subject to policies that were intended to minimize access to goods, services, or healthcare. I think that policies should be trauma informed in the sense of thinking of how historically that impacted access and how now currently we need to leverage those trusted community settings, fund those settings as ways to address where people naturally get supports, and also fund strategies like Dr. Walker mentioned about providing care for the staff. I also want to highlight Dr. Clark's point about the importance of income inequality. Yes, there is a huge peer movement. And to your point, sir, we are paying our community health workers much higher than minimum wage. So that was very important to us, because we certainly didn't want to create a system where we're leveraging the trust of folks in the community, but we're not giving them enough money to make a living or to have economic access, most importantly, so that their children and their grandchildren can have a better quality of life. So I think all of those things are important, and important that historical trauma.
Yeah, Dr. Daniel Dawes, who is the executive director at Satcher Health Leadership Institute, actually coined the term political determinants of health. And we actually try and utilize that as a framework too, to think through how, legislatively and institutionally and constitutionally, we have set up certain communities to fail and have failed communities as well. And so if we think about it from that way, we can think holistically around what improvement really looks like. But if we speak about access, and to return to Dr. Walker's point, a few of our participants actually asked an important question for this panel specifically around telehealth service delivery. And Dr. Kennedy's point being that, some folks can have the technology, they have the ability, they have the broadband and the Wi-Fi and the means to be able to utilize it. And then some folks don't. And, I think I've heard anecdotally, we all agree telehealth needs to stay, but I'm thinking about how can we best utilize telehealth actually for those communities that don't have resources. I'm thinking of rural communities where are very resource deprived. So in New York City, there are significantly more availability of services, right? And then let's say in rural United States, telehealth could be something that's utilized, but what needs to happen to make that work? How do you all feel about telehealth being here to stay? And is there a way that the equity movement can be a part of this? So I saw Dr. Kennedy's hand, and then we'll go to Dr. Clark.
Yeah, just very quickly, I think that telehealth is definitely here to stay. I think that people have been talking about telehealth seemingly for like the past 10 years, and probably like the only good thing that came out of COVID is it just brought this thing to fruition as something that has become normalized. Like the idea of having a Zoom meeting with somebody 5 years ago was just completely ridiculous, whereas now it seems like the most natural thing to do, particularly like for a community where Dr. Walker serves. And you're quite right, Madhuri, inside Manhattan, there's no shortage of resources. There are programs for people to get access to devices, and that's definitely a factor that makes it more available. But you don't have to go too far out of the city. Where I live is about 20 miles north of the city, and it's the similar sorts of issues. It's very hard to get a provider. It's a very diverse community, and it's it's harder to get people to engage. And that's also a key part of the puzzle, because it's one thing putting the thing in place. I work on a geriatric unit. A lot of my elderly patients they don't understand the concepts of telehealth, and they just don't feel comfortable using the devices. Hearing is often difficult with some of these meetings. There's all these kind of technical issues to kind of grasp. But on the flip side, I have to say, I found it very useful in other aspects of practice. You know, I see other people, and seeing into their lives has been a fascinating insight. It's one thing when you see somebody in the office, but actually seeing into their home, it actually goes back to what I was saying earlier about giving you more of a sense of where this person exists into the world. Not to harp on, I know Dr. Clark will speak more to this, but I think it's definitely something that is a powerful tool for us to use moving forward.
Okay. Dr. Clark.
Yeah, Nigel's point is well taken. There are some efforts at the political level to make infrastructure for broadband more widely available. So it really means that people need to not see this as a Republican versus Democrat kind of an issue, but as a modern day issue, that we do have broadband, we do have access to other modes of communication that are essential. And we need to make sure that people who live in rural communities, people who live in the inner cities or barrios, or people who live on reservations or wherever have access to that ability. It's one thing to convince people to use it, but if they don't have access to it, then they can't use it. So broadband is increasingly a theme. The Biden-Harris administration is putting it forward. My hope is that it becomes a bipartisan consideration, just like roads and bridges, that nowadays that's an important part. And from a behavioral health point of view, that's from an equity point of view, not a behavioral health point of view, from an equity point of view, which is larger than behavioral health, that's what we're talking about. If I have access to it, oddly enough, it's not just telehealth, but it's telework. There are some jobs that decided, oh, you know, I don't need a brick and mortar plant. I can work with somebody from remotely, and a lot of jobs are still remote. I take the train to work, and because school's back in, but before the pandemic, I'd go to the train station, the Caltrain station, and the parking lot was jam-packed all the time. Now there's like 2 or 3 other people there. You know, I feel like, you know, exposed, because my car sits with like 2 or 3 other cars in a lot that's designed for maybe 150, 200 cars, because the companies are still doing telework.
Yeah.
So telehealth, telework, it's a modern paradigm in exchanging information. And people still do TikTok, social media, etc. So for recreational purposes, people are using their telephones, but it's harder to do that for telework and telehealth. So I agree with Dale, you can call people, that's great. But again, the potential for broadband in terms of enhancing communication, in terms of dealing with this freezing thing that happens when you have, you know, DSL, or just in case of you young people, Dale may remember, 56K. That's an important consideration. So what we can do is recommend that broadband is an important part of equity be encouraged, and not see it as a partisan issue, but as an essential issue for the modern society.
Absolutely. And I think it's also begging the question too, like our traditional ideals of best practice or best perfect care can be reformed, right? We can think differently about how we treat someone and what that looks like, and it can end up being really effective. So looking at the time, Dr. Walker, you will give us our closing comment of the day, and then we'll take it from there.
Well, I'll try to finish on something about the telehealth. I've worked for a long time before video was the issue, and I had telephone work. But both telephone and video require something else, and that is they need to know who you are. You need to, if you're going to do this with a community, you need to go visit and let them see your face and see your style of interacting, and you can see theirs. And so then you're more kind of like this group we're on right now. We're all pretty comfortable with each other. We can smile and laugh with each other because we know our backgrounds and we have something to deal with. And I think that's very important from a therapeutic point of view. Starting telehealth and never having seen the patient is more difficult. And so I would recommend if those who are listening that, make contact with the people, have good feeling about what you're doing, and then you can do telehealth.
Yep. Okay. So this is obviously, this will be the thing I sound like a broken record around. We could talk about this for an entire day, 2 days, an entire symposium. And I actually hope that that's something that comes out of this. And as I told our participants in the last session as well, that there will be follow-up to this in terms of what we can do as a group and as a community to improve clinical services delivery and focus and be able to tackle some of the issues that have been brought up today. I want to thank you all for your openness, for your time, for your candor, the respect you had for each other, and as well for being service providers during a time where none of us were ever trained to do any of this through a pandemic, and the sheer exhaustion we feel as well being service providers continuing to do it through a pandemic. You are champions of equity in your roles, and I could not do this work without your collaboration, so I sincerely thank you. To our participants, we have come to the conclusion of day one. And this has been an outstanding first day. It's a true pleasure to be at the table with experts that we brought together today. I know going into tomorrow, I so look forward to hearing about how mental health translates to cultural humility and sensitivity and how we uplift the voices of the invisible. I hope you will be joining us for another rich and meaningful dialogue. Your Zoom link from today will work tomorrow. And so I look forward to seeing you all at 11 a.m. Eastern Standard Time. Thank you so much. Have a wonderful afternoon, and we will see you in the morning.
Goodbye, everybody.
Take care. It was a pleasure meeting with you.
Good to meet you. Yes.
Thank you so much, everyone.
Marvelous
Take
group.
care.
And Wesley's disappeared. He's such an old friend and always has great things to say. You guys were incredible. Nigel, I studied 6 months at the Royal Free Hospital.
Oh, right. I see. Yeah, I trained at St. George's and I was at Imperial, but I know the Royal Free very well.
Oh, and I know St. George's. I played rugby against them.
Oh, really? I have to confess, I never played. But I played football a few times. But it's a small world. But great to meet you, Roger. Great to meet you, Sydney.
Yes, Nigel and Dale, it was a pleasure. Midori, it's so nice to learn of our common connections in New York and look forward to future collaborations.
Absolutely. Thank you. Thank you all so much. I really appreciate it. I look forward to being in touch with you again. And please, if there's anything I can do to collaborate with you, you all have my contact info. Reach out and hopefully we can continue to do this together.
Awesome.
I'd love to talk with you all more. It's great. Thank you.
Okay.
Likewise.
Have a great afternoon. Thanks so much.
Bye-bye.
Bye, everybody.